Well, hello everybody who's joining. Hope you all are having some fair weather. I know some of you are having some colder weather than normal, but just waiting for a few more people to join. Well, thank you again for everybody. It is 3:01, so we better get going, stay on time. My name is Alana Jarman. I'm a coalition co-lead for Mountain Pacific Quality Health. And we appreciate that you guys have taken time out of your busy days to join us for our regional coalition updates for the coalition members. So I want to open this up. We have our CEO, Sarah Medley, on the call, and she just wanted to say a few words of regards for you guys. So floor is yours, Sarah.
Thank you, Alana, and thank you, our Mountain Pacific team members. Welcome, everybody. I see David is to my right, and so thank you for all the work you're doing in pulling all of this together. We're now still in COVID mode. We were all hoping that that would not be the case by now, but it is. And so thank you for working with us and doing your all to stay safe. So thank you, Alana, for letting me just welcome everyone. I know a couple of our board members were going to join us. I don't know if Bob Janicek is on or Dr. Barb Doty. Are either of you two on? I'm looking at the participant list and not seeing that.
Hey, Sarah, this is Bob. I'm on. I just couldn't change my screen name, so I look like a funny U number.
There you are. Yes, you do. You do indeed. Well, thank you for taking time out of your busy schedule. Bob, do you want to say a couple of words about what you do professionally and your role with Mountain Pacific?
Sure. Thanks, Sarah. So I'm Bob Janicek. I am the Vice President of Network Operations for Blue Cross Blue Shield of Montana. I joined the Mountain Pacific Quality Health Board last year. Been on the board just over a year now. They've allowed me to stay, so that's a positive thing. And it has been extremely interesting getting more insight into what Mountain Pacific Quality Health can do to further the care delivery in our communities. So Sarah, I am glad to be here, and I'm really excited to hear what we can glean from our partners here in the communities.
Gosh, thank you so much, Bob. We appreciate you as well. So what about Dr. Barb Doty? Is Barb Doty on? I'm thinking not. So with that, I will turn it back over to you, Alana.
Awesome. Thank you so much for both of you for joining. And I know we also have our CMS Task Order Director, Mary Erickson, is on the line too. I don't know if Mary, if you wanted to say a few words as well.
Just want to say hi, everybody. I've seen kind of the draft of this presentation today, and I'm excited to hear from our coalitions about the work that you're all doing. So thanks, Alana. I won't take up too much of your time.
Awesome. Well, again, thank you again. And yes, we do have some awesome showcases. So with that, we actually are starting with the first one. And we have Crystal Morris and Nicole Zeal coming on to talk about PFAC and being a powerful partner. So I will open it up to you two.
Well, thanks, Alana. Hi, everyone. My name's Crystal Morse, and I'm located here in Casper, Wyoming. My role as an account manager is to assist with our patient engagement initiatives here at Mountain Pacific. So today, it's going to be my pleasure to introduce Nicole Zeal, who is one of Mountain Pacific's original powerful partners. 3 years ago when I approached Nicole about the idea of serving on our Patient Family Advisory Council. It was her response that made me smile. And that's what I really needed to hear from her. What she said to me is, Crystal, you've given me a purpose and a way to make a difference. So I want to, since Nicole has joined our team, she's accomplished so much, and I want to share a few with you. First of all, Nicole was elected to a national Patient Family Centered Care Patient Family Advisory Network Advisory Board. She's volunteered in an Aging in America conference. She served as a caregiver panelist at our 2019 Wyoming Quality Healthcare Conference. She's received national recognition at the CMS Quality Conference in Baltimore, replacing the visitor tag in our community healthcare settings. And lastly, here at a local level, Nicole has presented to our community hospital, chronic care case managers, and our coalition. So now let me hand it over to Nicole. You take it from here.
Okay. Everyone hearing me okay? Doing just fine in rural Wyoming? Hi, I'm Nicole. I am a married mother of 2 grown children. I provided direct care to my grandparents for over 10 years. In the last year of my grandmother's life, I moved in with her and gave direct care to her. And I currently share with my husband the duties of caring for his parents, my in-laws. They are both in their mid-80s and have various health challenges. I wanted to be clear to you that today I'm speaking to you as the role that you may know of as an informal caregiver. So wasn't paid, I paid people to come help me, but I was the informal caregiver. So I encourage you to think of us informal caregivers as not always the spouse. I know that I always bucked the trend that I wasn't the daughter, or I wasn't, in the case of my grandfather, I wasn't his daughter. I was the granddaughter, and sometimes that was surprising for those in the healthcare setting. And but that's the role that I fell into, and so I just challenge you to think of the caregiver as not always the typical spouse or child of the person. So I was the granddaughter of 2 very rural, like smallest county in the smallest state in the nation people, seniors. And when they moved to Casper to receive care, they could not drive in this town, let alone find the doctors that were in their obscure buildings. They could not manage to decide what they wanted to eat at our restaurants because the menus were so extensive, let alone remember what the name of that new medicine was that the doctor they had just come from had just recently prescribed. It wasn't that they were helpless. They were just lost in our very large system, and I became their navigator. I know that there's one other patient family advisor on our local PFAC who is the caregiver for her neighbor who is going through breast cancer, and her children live in another state. And so my friend has picked up to help with the neighbor and goes to her meetings and her visits and helps relay that information and bridges the gap for the family. So just something for you to remember when you think of the face of a caregiver. Through my care journey, I've gained experience in many different medical health care settings and medical issues. I'm also an AHIMA certified medical coder. It was in school that I learned about how Medicare influences the care that my loved ones receive. I began to realize what those questions were that they asked at the end of every hospital stay. I began to realize what the triple aim was, and oh, how I could have an influence in that. It's also important for you to know that as I speak about my grandmother, she had had a stroke that affected her speech and her thought process. But over 10 years, I learned her language and I knew the way her mind chose her words. Sometimes it was difficult, but I understood her as no one else could. And I was careful not to put words into her mouth, but she needed my voice. I've embraced the opportunity to serve as a powerful partner to Mountain Pacific Quality Health and represent a voice in patient-centered experiences. Frankly, it just gets me excited. Caregivers are essential contributors to the outcomes of medical successes. I hope that my perspective as a caregiver can encourage you to better understand the difficulties in the healthcare setting. And my intent is to assist the process of improving care by sharing my story, so that the quality of life of not only the patient, but the caregiver can also be enhanced. I hope you like that picture of my grandmother. It sure gives me some tears when I look at it. That's her hand in mine. So very sweet. Go to the next slide for me, please. So here's what you're all here for, right? The triple aim. Let me show you how the caregiver can influence all three of these. First of all, let's start with reducing costs. It's quite possibly the biggest aim that caregivers can have the most significance on, I believe. After all, we care about reducing costs too. It's a two-way street. When caregivers are included in the medical decision process, we can assist with productivity. We can point out duplicate testing orders. We know that the patients, what medications they have on hand. We can tell you what equipment may or may not be needed or even used. We know the patient's financial situation and home life, and we can discuss if a treatment plan is truly sustainable. Do they have the finances or the mental stamina to sustain the proposed treatment? In my case, I was able to affect the cost effectiveness by changing her care location. I moved in with her because the long-term care costs were neither sustainable nor cost effective. And then let's go to population health, just to the left there. So let's start with the component that I felt I did all the time, and that was provider coordination. I always used to laugh that I was the scheduler. Not only did I have to think about what my family was doing, I still had 2 children at home actually for most of this. I had a senior in high school the last year of my grandmother's life. And so I was trying to balance not only my home life, but also my grandmother's life. And so a lot what I did was patient coordination. That was me. I kept the schedule of the bathing assistants, the PT, the OT, and the doctors for all the different specialties, and of course the social calendar for her. I was often able to call schedulers and get appointments on the same building at the same time, because the less I had to take her out, the easier it was on her and me. I believe that this plays into resource allocation naturally also. So getting the blood test done at the same time for both doctors, that was an example of how I could prevent or help with resource allocation. Risk management is also a natural fit for a caregiver. Many times I interjected to a provider that my grandmother was CKD stage 3, and all of a sudden the treatment plan was changed. A few times I prevented medical mistakes simply because I knew what had already been done to her. Duplications of immunizations can be reduced. For example, it's because it's the caregiver who knows that the last time the patient went to the pharmacy, they got the flu shot. But I could also point out she hadn't had the shingles vaccine. So I encourage you to remember the big picture that the caregiver has and use them to influence this aim so that it becomes a positive experience. Now on to my favorite. This is the one that I got really excited with Crystal one day, is the patient experience. A caregiver is the one who makes the patient feel most secure simply by being present during exams, tests, and procedures. In my grandmother's case, a trusted caregiver's presence was helpful in cases where dementia or stroke could have caused insecurity. The caregiver can relay information in a more familiar vocabulary and offer suggestions for a successful encounter. I'm going to give you an example of that in a minute. Patient satisfaction. For various reasons, the caregiver assists in filling out the HCAP surveys. You know how important those are. My mother-in-law fills them out currently for my father-in-law, but I was the one who filled out the HCAPs for my grandmother. She wasn't able to read or write due to the stroke, so my experience in the facility influenced what she would have reported. The shared decision-making of the caregiver and with discharge planning is essential for a quality outcome. The success of a patient's outcome is frequently in the caregiver's hands. They're often the ones who administrate medications, the blood test, the oxygen, and other medical procedures. And it pays to train the caregiver in the setting so they can be equipped to handle all they have to do at home, often alone. I started to look at some of the statistics, and it's from the National Family Caregiver website, and they were saying that 63% of medical procedures are done by untrained caregivers. And so if you're interested in that, I encourage you to look those up, that there's a lot that the caregiver sent home to do that they may not feel equipped to do. And that's where an outcome looks poorly in the triple aim, but when it could have been improved had the caregiver been better set up for success. The biggest issue and outcomes exist in the prevention of readmissions. I cannot stress it enough that if the caregiver is set up for success, readmission rates will decrease. We can be instrumental in making sure the home environment is staged for the patient's success and that the care plan is followed. I've always put it in big, bold letters: teach us, trust us, and help us to help you. Safety for the patient is also affected by and influenced by the caregiver. I was able to prevent several medication errors by my comprehension of the entire medical scenario. My grandmother would also smile and bob her head yes to every question that was asked of her. Her misunderstandings could sometimes only be identified by me as her grandmother. I was the one that could read her face and say, yeah, she didn't get any of that, even though she was bobbing her head yes. She was always eager to please and didn't comprehend that she didn't even misunderstand the instructions. When I was telling you about the vocabulary that her and I knew, here's an example. One time a respiratory therapist kept trying to tell her to take a deep breath, keep taking a deep breath. Well, she couldn't understand that, whether it was just from her lack of vocabulary notice, but I would say, sniff the roses, because I knew she loved roses. And so I could get her to take a deep, full, long breath by saying, sniff the roses. So that's an example of how her safety was enhanced by being in a relationship with me. The caregiver can make observations about the environment also that can help ensure both in and out of the hospital. Together as caregivers and the medical team, we achieve the triple aim. We improve the patient's experience, we reduce cost, and we improve population health. You can go to the next slide. So here we are with you. Here we are at the local coalition. And so you see that we all have common goals with outcomes and metrics. As we've talked about, those would be the triple aim. And then we lead into the local coalition. The local coalition is made up of healthcare organizations, service organizations, and patients, families, and caregivers. As Crystal had mentioned, I had the opportunity to speak to our local hospital coalition and met with varied healthcare professionals and community partners. I was able to share my experiences as a caregiver within our healthcare system. It's complicated and honestly frightening to manage. However, being engaged and adding the caregiver to the team empowers us all to have a seat at the table, to feel supported and well prepared to care for our loved ones. At the end of the day, we all have the same vision. It's to improve patient-centered care and health incomes. Any questions?
Well, wonderful perspective. I really appreciate that. I think we all do.
Thank you.
Thank you so much. And just for the sake of time, I think we'll skip to the next one. If you do have any questions or comments for Crystal or Nicole, you guys can, we'll save some time at the end, hopefully. So up next, I have Kyla and Stephanie. So the floor is yours.
So this is Kyla Newland, and I am another staff member at Mountain Pacific Quality Health, helping to support the coalition work in Alaska. And I am here to introduce Stephanie Stillwell. I've gotten to know her over the past 9 months and the work that her coalition is doing in a fairly rural community in Alaska. They are working on their opioid task force, but really the work that I've seen and been involved with supporting is really a lot of community resources development and sharing. So I'm just so impressed with their group and how activated and engaged they are in this coalition work. So I'm happy to have her here to present to you today.
All right. Hi, everybody. I'm Stephanie Stillwell. I kind of wish that I would have instead of having the logo in the background of this presentation, I actually had a picture, a map of Alaska, so I could point you to exactly where I am. But so I'm here representing the Southern Kenai Peninsula Opioid Task Force, which is located at the southern end of the Kenai Peninsula. So it's about 220 road miles south of Anchorage. So one road in, one road out, all the way down. And then that's like the primary area where this particular task force focuses its energy. But in Alaska, resources are very limited. And so we do a lot of sharing and networking throughout the state. But I am a nurse as a background, working in background is public health and psychiatry. And I have transitioned away from conventional nursing and created my own nurse consulting company. So I have a lot of different projects throughout the state of Alaska. And one just happens to be facilitating this amazing coalition down in the Kenai Peninsula. So let's see. Why don't you go on to the next slide here? And we are celebrating our 3rd year in existence. So I'm just going to start by giving you a little bit of history on kind of what prompted us to start this particular coalition, and then kind of move through the timeline of where we are, and then also dig into a little bit of, where we get our data and how we've kind of helped keep ourselves moving in the right direction. So like I said, we started about just over 3 years ago now. And the real intention behind the coalition or the task force was to create intentional connection and dialogue between community partners and community members about substance misuse. So although we are the opioid task force, we really do focus on all substances, but just in particular, we're really focusing a lot of our energy into the opioid crisis. And so we were also responding to the community's questions of where can we get help, and responding to our community health needs assessment that I'll touch on the next slide for just a brief minute. And of course, statewide, looking at statewide and national data, and really looking to assess our current resources and what we have available in the community on the southern end of the peninsula, and statewide, and identifying the gaps and service and treatment services, and how we can help to facilitate closing those gaps and closing those silos. Next slide, please. Okay, so kind of the year before we officially started the task force, so back in 2016, statewide and locally, we were having a lot of positive rates and increased rates of hepatitis C. And so we realized at that point we really did need to do something to address that immediately. And so we partnered with a couple of different agencies in the community and people who were in the active using and recovery community, and started the local needle exchange program. And so that was a huge step in the right direction. And around the same time, we were conducting through one of our wellness coalitions, MAP, that Kyla has been involved in the past as well, a community health needs assessment that really conducts a kind of a holistic and comprehensive assessment of the community's strengths and needs. And so those were conducted all for in 2008, 2012, and 2015. And across the board, the number one factor that was negatively affecting the community was substance abuse. And so, that in itself was just a huge eye-opener that, that didn't change throughout that, and we really needed to do something more. Along the same time, in the state of Alaska, the Department of Health and Social Services declared a disaster on the opioid crisis, which led to us being able to distribute Narcan statewide through something called Project Hope. So that was a really great way to start conversations as well. And at the same time, our local hospital was noticing a real big increase in babies being born addicted and having a lot more families that were affected negatively by substance misuse. And so I was at that time working as a public health nurse, and they came to me and they were like, what are our resources? What do we have? Come to the table. We need to have these conversations and we need to start because we just don't know what to do. And so we really started to, so what I started to do was work together with the community to figure out exactly what our resources were. What did we have in the community? What were we missing? And created something that we use now is called the Road to Recovery Pathway. Which highlights all of the resources that we do have locally and statewide, and also for people who don't understand how tricky it is to navigate that system to go from being in active addiction to recovery, and what that actually looks like, and how many steps there is, and how long of a process that really is, and why it's so important for us to have the supports available for people as they go through that, both family and those going through the treatment services themselves. And so then that kind of led into community conversations and town halls, and getting partnering with the state, with the DHSS, to hold some really good conversations in town halls. And then our very first opioid task force meeting was in July of 2017. Okay, next slide. Other way. There we go. One more. There we go. So this is just a snapshot. I'm not going to get into the details because I know we don't have a whole lot of time, but so this was just kind of an idea of where we started in 2017. So we had, like, it looks like there's 3 options for withdrawal management, but they weren't really. Those were like outpatient ambulatory detox facilities. We had very limited options for outpatient treatments, 0 residential services, 0 sober living, and very limited. We had maybe a few 12-step programs in the community, but really not a whole lot. So fast forward to now, if you want to tag on to the next slide. I'm also not going to dig into this, but you can now view our actual virtual interactive Road to Recovery pathway on the website that we put out this year. It's allthingsaddiction.net. And it's both educational, but also, like Kyla had mentioned, it's kind of a directory of resources for things related to addiction and treatment options, both locally on the southern end of the peninsula, in the entire peninsula, and statewide. And we have grown tremendously because of every month having intentional conversations, busting down silos, and connecting people from all sorts of areas in the community. We've been able to really make a lot of progress with everything from increased providers for medication-assisted treatment to we actually do have our own residential facility for treatment in Homer now. So that's really huge. That was when we first started talking, people kind of thought that was just very dreamy, but we were able to partner with the right people and make that happen. So super exciting. And you can head on to the next slide, please. And so as this, as our task force started to grow, it started with, 5 people around the table from community agencies, all the way now to we have, I think, about 400 people on our listserv in a community of 5,000. So that's quite a bit of, just people somewhat engaging. And we've been meeting for every month for the last 3 years, and we still have anywhere between 20 and 40 people engaged in our monthly task force meetings. So we needed to do some restructuring and some strategic planning. So last year we spent a good amount of time really digging into what our focus areas what we wanted to focus on, because of course this is such a huge issue. We needed some direction to keep us moving forward. So we really honed in on reducing stigma, focusing on prevention, and increasing access to effective and affordable treatment. And then of course, continuing to improve our task force capacity and growing in that direction. Next slide. And so to do the work, we broke down further into work groups. So we have 4 primary work groups and then a few ad hoc work groups that we come together. So we have our prevention work group, treatment work group, community outreach work group, and our policy work group. And then additionally, we do have a data work group when we need some people to dig through some data, and some leadership work group to do things like strategic planning and things like that. Right now, our most active work groups are prevention and treatment. Community outreach kind of took a slide with COVID, so I'm hoping to re-energize that soon, but policy is kind of set aside for the moment. We didn't have a whole lot of people super excited to engage in that yet, so hopefully we'll get some movement there. But you can head to the next slide, please. So our treatment work group really, the plan with this and what we've been working on is to just really continue to assess our treatment resources and keep that resource list updated, digging into you know, how we can continue to help fill the gaps. And let me see, I think the next slide might have what a, let's see, go ahead to the next slide. There we go. Yeah. So with this work group, the next big thing that we're trying to tackle is the issue of detox. So there's very few detox beds in the state of Alaska. And if you don't know how big Alaska is, 75% of the state is actually located off of the road system. So you have to take a plane into Anchorage to actually get to detox oftentimes. From our community, it's, you know, there's one road in and out, but with winter coming and even year round, it's one road going through the mountains, and it's a bit tumultuous sometimes to get to Anchorage. And even still, there's there's always a need for detox beds. So we are going to try to look at, you know, making sure that there's a full continuum of care on the peninsula, including having a dedicated detox facility, or at least detox beds in our hospital, and something for aftercare, sober living and recovery residencies. And so we're, to bring in some data into this, we're going to be digging in to a lot of data about well, I think I have it on the last slide I'll get to, but a lot of data statewide to see how you know, not having a detox facility affects the emergency departments and what that looks like to the local hospitals. And so we're going to try to dig into some info there, because we know it's a huge project to tackle, to try to get detox. There's a whole lot of things that are challenging in that department. So just calling in the right folks again around the table to intentionally talk about this and move forward strategically. So next slide, please. All right, and then 9 months ago, when Kyla and I started talking, she's like, what can I do to help you? And we had really just started getting our work groups going, and immediately she was the answer to a lot of questions that I had for our prevention work group. She was a wealth of knowledge for a lot of things that we were working on and bringing data and getting us on the right track. So with this work group, prevention was kind of defined as, you know, in our community, we also have a resilience coalition that focuses more on the ACEs and prevention on that really root level, children and family. So we kind of started looking at, well, what can we do for prevention as far as like low-hanging fruit, things that we can kind of cut the supply and kind of prevent it on that level. So we've worked through a couple of different things, including getting a promoting the state of Alaska's voluntary non-opioid advance directive, which is an advance directive just like you would use for other advance directives in the hospital. Basically, it's for people who don't want to have, unless there's like traumatic injury or things like that, who don't wish to be prescribed any type of opioid medications while they're in the hospital or outpatient. This also will help people to, it's another conversation that folks can have about opioids with patients. And it also allows for, prevention of people who maybe have a history of substance misuse or something like that, for just another added layer of protection there. So, and then we're moving on to a couple of other work projects through this work group that Kyla has been wonderful about getting us some of the data that we're looking at, including moving forward to looking at alternative pain management pathways and working on pharmacy partial fills for controlled substances. So that's been really helpful to have a wealth of knowledge from her there. Let's see, if you want to go to the next slide, I think we're pretty, okay, yep. So this is just something that we did for fun at the last work group or the last task force meeting. Just I've got looking at another way of getting some more subjective data for what we can do for our non-pharmacologic alternative pain management pathway. And then one more slide over is just some more of the data that we have used to extrapolate some information out of, and what we're looking at doing next for digging into this year. But I want to just add that a lot of the data is hard for us to use in real time because things are 2 years behind. So what we've had to do a lot with this work is looking at subjective data and getting real-time stories over statistics to really be able to move forward. So talking with people in the community who are either actively using or are in recovery, or people working in agencies. It's just really that big collaborative effort to see what's really going on. And then 2 years later, we can see that the data aligned with what we were seeing in our community. So yeah, so a lot of it's just been just really getting data while we can, but moving forward from just following the energy in the community and getting people around the table. So, and I think that's really it. The next few slides were just some exciting news stories and outcomes and things like that, the fun stuff that we've gotten to do over the course of the last few years together. So, but thank you. And I think that's about it.
Thank you so much, Stephanie.
Oh, that was great. And I really do appreciate, you had mentioned too with ACEs and kind of the mental health component and understanding that needs to be a big part of it. So up next actually is myself and Dave Wanzenreed. He is the Billings Community Coalition lead in Billings, Montana, and I have been helping him. Dave has done a phenomenal job since coming on in March. And Dave, I'll let you introduce yourself briefly, and then you can just take it away.
Okay. Well, I'm really humbled in the presence of all the presentations that have been made. So I'm here to talk a little bit about what we've done in Billings. And obviously for the last 8 months, it's safe to say that everyone has been preoccupied with COVID-19. Healthcare professionals, providers, all the support groups that I've worked with since I started have insisted that the only thing they want to talk about is COVID-19 and the pandemic. And while I think that's a good idea, all of the issues that were around when the coalition was formed in 2015 continue to be there. They're just bubbling right below the surface. And so what I've tried to do since I started in March is try to reach out and play to that interest that they have in COVID-19, but to kind of move away from it. When the coalition was established in 2015, it set out, like all of your coalitions, to do a number of things. And I think it's safe to say when I started in March, most of the people that were involved were marginally involved. It was meeting to meeting. Oh, I'll skip this meeting and take part in the next meeting, but no real true commitment. And that continued to be the case really from the time I started until back in August. I finally found something that everybody responded to. I've tried a number of things to energize interest. And one of the things I did was I set up a blog thinking that it would be a way for everyone in the coalition. And there's probably, I have about 125 to 130 people that claim to be interested in receiving emails mostly. So I was thinking a blog would be some way to have them begin to interact with one another through the information exchange. And while I thought that was a good idea when I started, I found out that most of the people work for organizations that block them from accessing blogs. So I gravitated away from that. And each of the meetings that we've had, we meet monthly on the fourth Thursday of every month, and we spend an hour every month talking about the topic of the month. And for the first 3 or 4 meetings, as I said earlier, we dealt exclusively with COVID-19. I had the state medical officer on the line talking about a statewide perspective. I had the local health officer and CEO here in Billings talking about what was going on with COVID-19 as it applies to this area. In August, I had a friend of mine who's a psychiatric pharmacist make a presentation about the difficulty that older adults have in taking medication. And it was a pretty tame presentation, but it was jam full of statistics about what happens, what are the consequences to all of us, families, patients, caregivers, healthcare professionals, providers across the board, all the consequences of that, the costs in terms of lives, the missed opportunities for the medications to really have their full effect. And shortly after we adjourned the meeting, I was literally flooded with emails saying, we need to do something about that. And it was the first time really in 5 or 6 months that something kind of clicked. And so we found something that people were interested. They said, we need to do something about it without being very clear. And so, like all of you, the first thing I did was to do a Google search and found that there really wasn't much in the way of a guidebook, something that we could all share. And so I began to put together in short order a booklet, a guidebook. And I sent it out to 4 or 5 people that had insisted that we need to do something. And they began to put their fingerprints on it. They began to invest some interest in the organization and what it could do for, not them, but the people they serve. And I had a very good cross-section of individuals. When we were about done with the first draft, they had forwarded that initial draft out. So I sent it out and that group slowly expanded. And when we were done with the third draft that we've worked on, I had about 50 people, not all of whom are part of our coalition here in Billings or in South Central Montana, but people across Montana and in some other states weighing in, saying, what you need to do is you need to add this or leave this out. And while the consensus at the beginning was the document was too long, more people than not said we need to add more. So I broke it into sections, and now that we've had some discussions about it with the coalition as recently as last week, we've decided that we're going to come up with a booklet that's capable of being printed in sections. And I understand that it's probably too long to be displayed. It's rather lengthy, but I'd like to send it to any one of you that's interested and ask you to take a look at it, because I found there's really nothing out there that's user-friendly for families. There's a lot of stuff for professionals, pharmacists, physicians, and some professional caregivers, but nothing really geared for families and caregivers of the type that all of us are familiar with. So what I'd like to do is to offer that up as a way of engendering some exchanges between the coalitions. I don't know, for example, all the coalitions that are in Montana, and I certainly don't know the ones that are in the other states and other territories. But I'm a big believer in exchanges of information of the type that we have done today, and think that we ought to do something about that in a more formal way. And so I've had some discussions with Mountain Pacific about creating a place, I don't know exactly how to say this, but a place on its website for coalition information so that we can share information between us. I'd like to know that my draft has been shared as broadly as possible with people to weigh in with their different perspectives about how they feel about it, things that ought to be added or deleted. And I'd like to know what each of the coalitions is doing. And so I've asked Alona to display my email address, and I'd like you to put me on your contact list. And I'd like to have you send me the things that you do every month, things you have, that your activities, the products that are produced, the interim projects that you're working on, so that it doesn't have to take a quarterly meeting for me to do it all in one fell swoop, and I can digest it over time. The reason I think that's important is because we all think that we're different, but we all have common interests. And my guess is, for example, of the presentation about caregiving, that's something that we can do something about. We can actually provide opportunities for people to be strengthened as caregivers at the family level. And certainly with opioid, that's something, opioid abuse is something that all of us have an investment in, especially in rural areas. So I would like to encourage all of you to share your information with me, and I'd like to share information with you. And I'm thinking that Mountain Pacific is a partner of all of ours, can help facilitate that, and we can post finished products so that they can be shared more broadly amongst the coalitions that are in the different states and the people that they serve. And that's my 5-minute pitch. I appreciate the opportunity to have been asked to explain what we've done here. It's pretty modest, but I figure that if we have little pony steps starting out, before too much longer, we'll trot. And perhaps after that, we'll be catching up with the rest of the rest of the coalitions that are ahead of us. Alona, I'll send it back to you, and I'll be happy to answer any questions.
Well, great. Thank you, Dave. And, you know, it's really been invigorating, I guess, you know, in time of COVID. I think a lot of the coalitions were struggling with how to meet, what kind of platforms to use, you know, whether it was Zoom or Skype or whatever else type of ways. And I really have to commend Dave for really being creative and thinking outside the box. I don't know if you guys saw that on there, that he created a blog site just to be able to update his coalition members and to garner some feedback from them. Also used really creative ways, like sent out some postcards, because we all know that during the pandemic, our inboxes, our email inboxes were getting inundated by email after email. So in order to catch the attention, he's done a really great job at keeping coalition members engaged and really wanting to hear their voices. So thank you, Dave.
I have to tell you, I had to ask Mountain Pacific to violate its Paperwork Reduction Act by sending out a postcard, but it turned out to be something that really kind of broke through the barrier of thousands and thousands of emails that all of us get every single day. And it served as a way for people to contact me sort of outside of that box by calling me. And I have to tell all of you, I haven't met 99% of the people that I've worked with in person. It's all been Zoom meetings, virtual meetings since I started. So Mountain Pacific, thank you for your help, and thank you for being a good resource.
Thank you. Thank you for all what you guys do. It's an honor to work with so many amazing people and the amazing work that we get to hear about during these showcases. So thank you again. We wanted to provide a couple updates from Mountain Pacific side now. I will start and then I'll turn it over to Stevie and Caitlin if they want to talk about the chronic disease and COVID land. But with the first box there, you see nursing home TikToks. I don't know if you are familiar. It was just during the pandemic, my oldest son, he was talking about TikTok. And I'm like, what is this TikTok? And so anyway, that's where the name comes in, but TIC meaning trauma-informed care. So CMS recently created regulations for nursing homes to implement and assess and screen trauma-informed care within their facilities. And so just as a way to provide some additional support for that, we wanted to pull in some subject matter experts on that. And so this is going to be a 10-part series. We'll begin on November 18th. The save the date and registration for that will be forthcoming. So just be looking out. And if you are not signed up in any of our constant contact lists, that's generally how we send out the upcoming events. Or else you can go to our Mountain Pacific website for upcoming events tabs. So Caitlin and Stevie, I think, do you guys want to speak on the COVID and chronic disease regional land?
Sure, thank you, Alana. So the second part of our 3-part series is kicking off. It kicked off last Tuesday. We are covering COVID and diabetes care. As we're all probably aware, COVID is really surging in the United States right now. Our region is no different. So we're still covering our COVID numbers every other week, and also talking about best practices to improve patient engagement in their diabetes care to help improve outcomes. Our next session will be November 5th. That is a Thursday rather than our usual Tuesday. We did move because of Election Day, so that we all have time to do our civic duty. So we'll look forward to seeing everyone on November 5th.
Thanks, Stevie, for sharing that. And yes, definitely join us as we talk about diabetes and empowering our patients during this pandemic. We are also, you have maybe seen that, and thank you to many for helping, but we've been working on adding to our recruitment and recruiting diabetes prevention programs, so the DPP sites as well. So we are still in the process of that. So if you have connections to those and can help with that, we're hoping to get them recruited into either the local coalition, depending on the work you're doing, as I know many of you are wanting to work on chronic disease. And then if they're not appropriate for the local coalition, we would like to recruit them for a regional learning and action network that we are getting started around chronic disease. So lots of great opportunities and lots going on. So we continue to thank you for the connections and the support in these areas.
All right, thank you. And care transitions, care coordination work group. Anybody from Mountain Pacific want to give any updates on that work? Don't be shy. So I will go. So with some of the creative ways that we've been actively listening to the coalitions and the work that everybody is doing, the 4 M's, I don't know if anybody's familiar with the 4 M's. It is a very vetted tool that has been created and is actually a national initiative. And so we've heard a few different coalitions discuss issues on the terms of nursing home residents back into hospitals and hospital back into nursing home care coordination process. And so we're just trying to, I guess the whole point of this is just that we're trying to keep track of all the different work that everybody's doing and any like work that you may be doing, and maybe sharing is caring with the tools and the process that you're doing within your community coalitions. And we're more than happy to get to be the conveners and help you guys get together across our states, whether you're from Wyoming or Alaska, it doesn't matter. we can get together and we can discuss some creative ways to come up with solutions with that. So, and then also with the education affinity group opportunities, data wish list. So again, going back to that data wish list that was sent out back in June to your coalition leads, that was completed, and we took that and we took it very seriously, and we're using that right now to come up with how to prioritize our work for the community coalitions. So the bulk of that was showing that diabetes was definitely a good focus, chronic disease. So moving forward, also from one of our last regional calls, we asked about data training and whether or not that would be beneficial for the coalitions, and many of you said yes. So Sarah Leek and Dorada Carpendo and I from Mountain Pacific are putting together a data training, or we actually started the data training series. The next one was actually tomorrow. If somebody from Mountain Pacific wouldn't mind putting that link in there as well, that you can join that session tomorrow. And if they're just 30-minute sessions, just kind of quick to the point. And we're going over the CMS. We're just covering QAPI basics first, the CMS QAPI principles. And then in November, we're going to start doing some more pragmatic work with our actual data and helping you understand your data. And that kind of goes to the next one, the CMS baseline data. I think the pandemic has thrown a wrench in a lot of people's work, including CMS. So we have been very patiently waiting on that. And so we are starting to kind of get trickles of that in. And so we want to be able to help your communities understand where to focus your priorities for your community coalitions. And then the last thing is the website revamp. So Mountain Pacific is taking a very structured approach to looking at our website, to making it useful and beneficial for everybody. So just so you know, if you do go on our website and you look up any of the resources on there, we are working internally to make that a little bit better. So anybody else want to have any last words of updates or from Mountain Pacific?
Kyla, I'll just add a little bit to that, the website revamp.
Speaking to what David said earlier, we are going to be building in some form a resource area for the community coalitions. So we will probably be looking to you guys as we do that to see what would be most useful to have on there.
Thank you, Kyla.
Yeah, Lona, and in Guam and American Samoa, we're doing a lot of sort of prep work for telehealth consults with the doctors who are down there, and trying to set them up with the Pacific Basin Telehealth Resource Center across the country. And we're just getting started. We're meeting with Guam today, and we've had a couple meetings in American Samoa. And we're trying to build that network up both for local community work between patients and their caregivers, providers, and then also nationally, how they can link up to other providers to get help with different things like radiology and COVID-19.
Thank you, Mark. Yeah, it's you know, we think about, you know, when Nicole was talking about her perspective in rural Wyoming, and we have American Samoa and Guam. We think about how some of us, you know, I live around Belgrade Bozeman area in Montana, and I mean, I have access to a Walmart, and I know, you know, I can get around, but those resources and those community resources that we think how to solutionize, I think I just made up a word, to help improve our outcomes. So I really appreciate you speaking up about that, Mark, because I think you know, having some pioneers and really thinking outside the box and thinking creative on how we can do our work together. Anybody else have just 1 or 2 minutes left?
This is Jill with the nursing home team, and I would just add that also in Hawaii, they are working on a land program. They've had one offering already, but it's for the nursing home providers on leadership and some staff retention and training tools. So I think we're starting to talk about things that are not directly related to COVID, but maybe the aftermath of COVID, in addition to the programs that you mentioned before, Alana, with the TikTok and the coalition work.
Yes, thank you.
Yeah, and we're grateful that Lona and Caitlin and Jill Clint, your referral for Clint, will all be providing presentations for that ECHO series. So thank you all very much.
Yes, thank you. And thank you all so much today for joining us. And I'm sorry we didn't get time for more questions and comments. You're more certainly to reach out to your Mountain Pacific connection, or you can email me if you have any questions or trying to get a hold of somebody or want to know more on something. So I will put my email into the chat box. Hopefully that I typed it right. So you can definitely email me if you have any questions or want to reach out to look for more resources, anything. So again, thank you again for sharing and being here today. Very much appreciate it.